First off, some introductions. My name is Dave Jones. I'm the media relations representative for McLaren Healthcare. And again, thank you all so much for taking the time out of your days to talk about a fantastic piece of clinical technology that we'll be bringing to the state of Michigan. And to turn it over, we're going to start with Dr. Justin Clamaris. He is the Executive Vice President and Chief Clinical Officer of McLaren Healthcare. So, Dr. Clamaris, uh,
Thank
all
you,
yours.
Dave. Good afternoon, everyone. Thank you so much for joining us and members of our team who you'll meet in just a moment. Dr. Sam Kazia, who's our Chief Medical Director for our McLaren Heart and Vascular Institute, as well as Nish Kandawala, the CEO of Bunker Hill. On behalf of McLaren Healthcare Corporation and the hundreds of thousands of patients that we touch every day in communities from the northern part of the lower peninsula all the way to the southern border of the state of Michigan. We are thrilled to talk about a new program that McLaren, along with Bunker Hill, will be releasing in the coming days. I think it's impossible to think about the topic that we're going through today and the use of artificial intelligence, machine learning technologies to help improve patient outcomes. If we didn't start with the consideration of the impact of cardiovascular disease in the United States. Heart disease is still the leading cause of death in the United States. I'm a medical oncologist by training. Cancer is the second leading cause of death. But we see so many patients across the state of Michigan who are impacted by cardiovascular disease. And what we know is much of cardiovascular disease is preventable if we could recognize patients who have symptoms or have evidence of disease earlier. This project and what we are launching with Bunker Hill, as Bunker Hill partners with other health systems across the country, is to use artificial intelligence and use the abilities that we have to extend our clinical care teams beyond the nurses and doctors who are taking care of you when you seek care in our facilities, but to use all the information that we have at our disposal, whether it's in imaging scans, whether it's in the medical record, to understand as much as we can about our patients so that we can do exactly that, which is help prevent illness, help prevent death from cardiovascular disease. McLaren Healthcare is privileged to serve individuals throughout the state of Michigan with over 25,000 employees and colleagues who help to deliver that care. I have the privilege of overseeing the medical and clinical care for patients across the state of Michigan. And we are so grateful for our talented team members, our doctors, our nurses, all of those who do this work in communities throughout our state. I think this program is really exciting because it reaches out into our primary care offices. It connects patients with what is known about them and their risk factors for disease. It brings together images that you'll hear about in just a moment, brings together a more sophisticated view that only machine learning, only artificial intelligence can help to do. But that is all to deliver better outcomes for our patients and to recognize problems sooner. You'll hear more about that today, but on behalf of our company, we look forward to sharing these details. I'd also just highlight that health systems throughout the country are already using artificial intelligence to improve our business and clinical operations. We have within our neurostroke program one of the largest stroke programs in the state of Michigan. We're using artificial intelligence already to try to identify vessels within the brain that have a higher propensity towards stroke to enhance our imaging recognition and technologies. But this is a critical one because it reaches so many patients, and we'll be releasing this program in the coming days, and we're happy to go over the details of our partnership with Bunker Hill. So Nish, I want to thank you for joining our panel today, joining members of our local media who've joined us to listen about this program, and I'll hand it over to you for your comments.
Thank you, Dr. Clamaris. It's so exciting to be here. Thanks for having me. My name is Nish. I am the CEO and one of the co-founders of Bunker Hill. At Bunker Hill, what we do is we enable health systems to have their clinical and operational teams to build and deploy different AI agents for use cases spanning very clinical domains to more administrative domains as well. This use case is one of my favorites. It really shows the power of AI where it's not the type of use case where you're trying to automate something that was done manually before, but it's actually trying to do something that was not possible, was not feasible to do before, and really driving better care for patients here. Um, this use case utilizes an algorithm that was developed at Stanford University. The chair of preventive cardiology there would see patients in his clinic after the patients have had a heart attack, and his job was obviously to prevent the second one. And he would routinely find patients that had come to Stanford Hospital 4 or 5 years ago for some entirely unrelated reason, maybe a car accident, maybe a cough or pneumonia visit. And it was apparent from scans that were done for that patient that this patient had many blockages in their arteries, but unfortunately, the patient fell to care gaps and had not had the opportunity to see a cardiologist. And so, what he and his team built was this AI model that can look at scans that are being done on patients for non-cardiovascular reasons and then actually drive them to get preventive cardiology care, so that they have better outcomes. My favorite story is actually from this past Thanksgiving, where we had someone who had a turkey bone stuck in their throat. And they came to the one of our partnering hospitals in the emergency department. They got a CT scan to get checked for that turkey bone that was stuck in their throat. And this program was able to identify that this patient actually had a very high risk for heart disease, for heart attack. And they got a letter from our program saying that they did have increased risk. They ended up seeing a cardiologist for the first time ever. And it turned out that this patient was actually experiencing chest pain. But like many others, he had dismissed that chest pain as heartburn. Um, and this patient ended up actually getting a bypass surgery, and hopefully we probably added a couple of years of better quality of life for that individual. So it just goes to show kind of with what the program that we're trying to build in collaboration with McLaren, and McLaren being the first one in Michigan to adopt this program, we could not have asked for better partners. Um, we are expecting to screen over 40,000 patients every year, and we project that we will be hopefully finding thousands of patients and driving them to better care. And we're excited to partner with McLaren on this front. I'll hand over to Dr. Kazia to go over more of the clinical aspects of the program here.
Thank you very much. This is a very important way of finding the disease before it causes any problems for the patient, long-term or short-term. We know clearly that there are multiple risk factors for cardiovascular disease. One of those risk factors, which now becoming more frequently asked for, is something called coronary calcium score. Coronary calcium score is one of the things we can look at to define whether the patient would be at higher risk for having a heart attack in the future. Those tests usually are ordered by physicians who are seeing patients actively, and they are concerned about the risk factors. So they do this test to really enhance the ability to risk stratify the patient, whether this patient would be at high risk for a heart attack in the future. What's happening here is we're really tackling this before even the patient is shown or seen by a physician. Those are patients who had undergone a CT scan for any other cause, such as a trauma or such as really pneumonia, or for any reason, whether it's with dye or without dye. But the ability of AI now to be able to calculate your calcium score automatically and provide this number to your primary care physician would be very, very valuable. Not only that, it will be able to calculate the calcification in the aortic valve, which is another reason where a patient might have a heart attack or a sudden cardiac death. So we will be able to ahead of time identify those patients who would be intermediate to high risk and have them seen by the physician so we can intervene upon this by prevention. So we don't end up seeing the patient, God forbid, emergently. The worst time for a patient to have a problem is to be seen in the emergency room emergently getting a procedure. It is always better to have things planned ahead of time, and a lot of times not even undergoing any procedures by becoming more actively involved in prevention. So AI is going to be now a tool for us to identify our citizens, our community patients who are having tests in the system ahead of time and alert them that something needs to be checked out and become proactive to take care of that for them, short and long term. I'm very excited about this. This speaks highly of the commitment by the McLaren health system to improve the care of the population. Is not just one patient at a time, but also population in general who are having testing in other places, in other CT scans around the system, and we can really identify those patients ahead of time and we can intervene upon them on the right time rather than after the fact. Dr. Klimaris?
Thank you, Dr. Kazia, and thank you, Nish, for sharing your perspective on this important new program that we will be launching. So just to summarize, what in our partnership with Bunker Hill, we are using FDA-cleared algorithms to look at retrospective images, images that have been done in the past and are sitting in our archives. We're going to be looking back 1 year in time to see if we can identify any of these early signals, any of these calcifications that would suggest that there's underlying risk for developing coronary artery disease or valvular heart disease. And we will be directing those patients, if they haven't received care, on how they can get that care. McLaren wants to be partners with our patients, with our staff, as I mentioned, our primary care team, our cardiologists stand ready to assist patients that we identify, to direct them to care. But importantly, as Dr. Kazia said, as these algorithms are run and identify patients, the key and our fervent hope is that we can be partners with our patients to make sure that risk factors are mitigated, that interventions are given to help control the things that help prevent patients from ultimately dying from heart disease or suffering from the morbidity associated with heart disease, stroke, or the many other complications that can ensue. So this is just one additional tool, but it's an exciting tool that we're hearing about all over media and both in healthcare and nearly every other facet of life. But we are confident that this tool is going to give our clinicians, our patients, more tools than they've historically had. So we're excited for that. And now we'd love to take any questions that the audience might have.
Yes, please. If you have any questions, you're welcome to put them in the chat, or you can raise your hand and we will get to them. All right. All right, Kristen, I have you. Kristen Seamus, can you hear me?
Yes, I can hear you. Can you hear me?
Yes, we can. You may ask away.
All right, wonderful. Thank you so much for doing this with us today. We really appreciate it. I'm curious, how are you going to notify patients who perhaps are identified in this way that you've seen something concerning? And what are those steps, and how do they get told about the AI component that's being used to evaluate their scans?
Great question, Kristen. So our initial workflow that we've envisioned is first of all, the AI algorithm with Bunker Hill helps to identify those patients. They take all the information from the medical record as well as the imaging reviews, and they identify those patients. We will be sending a letter to patients in traditional mail, identifying that there's what their projected calcium score is, either in the setting of the coronary artery calcification or the valvular calcification. We also, in the case of patients that are within our system, we will be sending electronic information, excuse me, to their provider. And in the case, generally, the AI algorithm is going to understand for patients that they don't have a cardiologist, that they may have a primary care physician. We'll be communicating that also at the same time with their physician. The letter will be outlining that an AI algorithm approved by the FDA was used on an imaging study that was done on the patient, and that the results indicate that there could be an element that warrants further review. And Dr. Kazia can go on into some of those details. But we wanted to make sure we're sending that direct communication to our patients, both by mail. That also, we're working to develop that so there's integration for the future into our patient portal, and then communicating to the primary care physician so further care can be coordinated for that patient if it's warranted. Dr. Kazia, any comments that you would highlight on our workflow that I didn't mention?
This would be also educational, obviously, to our patients. So not only they're going to provide it with a number, but we're going to be able to educate our patients about what does it mean. We don't want people to panic, but we want them to be aware that they are at risk. Just like telling somebody if you have diabetes or high blood pressure or high cholesterol, how you need to address it. This is another marker for cardiovascular disease and a very important marker. And I think this will work also very closely with their primary care physician or cardiologist to inform them about the risk. And there will be further testing performed on those patients, if required, to identify whether they are at a higher risk or intermediate risk. Not only testing, but also initiating medical therapy when needed. Any other questions?
Thank you very much. Kristen, is that good?
I have one more question, and that is, if you'd mentioned that if the patient's primary care physician is within the health system, they will get a notification. But what if your primary care physician is not within the health system and belongs to a different hospital system entirely? Will they still get notification?
They sure will, Kristen. What I was highlighting, we have two methods of communicating with physicians. One is those that are within our electronic health record. There's an electronic message that goes to, we use Cerner, to a message center, but there will also be a mailed copy of the AI finding and the summary, as well as considerations and resources that will be going to those physicians. At McLaren, we have over 5,000 physicians associated with our organization. About 20 to 25% of those physicians and providers are employed by our system. We have a long legacy of independent physicians, so we'll be communicating with any physician that's listed within the record. That's the primary care physician.
Excellent. Thank you so much.
You're
Thank
welcome.
you, Kristen. All right. And Ben, can, here we go. Ben, can you hear us? Ben? All right, Ben, we'll come back to you. All right. Ann, do we have you?
Yes. Hi, yes. Hi, can you hear me?
Yes, I can. Ben, we'll come back to you. I apologize. Ann?
Hey, I'm Annie Stabs. I'm with the Detroit News. I have just two questions. The first is, when are you going to start? You know, I know it's being launched now, basically, but is there a certain day you're going to start, you know, processing or doing, you know, launching, or I don't even know what the word is, starting to use the system? And then my other question is, do you have an estimate, or I guess do you have a prediction of how many patients this might be able to identify within a year? I guess I'm wondering how many people within your system in a set time frame will be identified generally.
Maybe I can speak to the anticipated launch, and I'll hand over to Nish and Dr. Kazia the estimates for patient volume. We have partnered. We began this partnership with Bunker Hill. And discussions over the summer and into the fall. We've been working with our IT teams and technical teams to make sure everything's directed, all the information is flowing. We're now in the phase where we can begin looking at some of the cohorts and populations of patients. We anticipate really within the next couple of weeks that we'll be releasing information, starting to release information to patients. We're looking back 1 year in time. And then also, since all the technology, these algorithms are plugged in to our systems, it'll be moving forward in a prospective manner as well. So real-time studies that are being done in our facilities, once we go live, the algorithm will be activated for those patients as well. But we anticipate, we've worked through the initial workflow, making sure all of the technical pieces are correct, all the safeguards, information security is in place, and now we're going through those initial an initial tranche of patients to review and make sure we've identified any workflow challenges, any considerations that we need to make sure that we safeguard this information and that we've got a good process in place. So within the next couple of weeks. Dr. Kazia, Nish, on anticipated patients.
Sure. I mean, we expect about 8 to 10% of patients who undergo CT scan through the system will end up being patients who have risk factors, such as elevated coronary calcium score or aortic valve calcium score, who have not seen a primary care physician or cardiologist. So those are patients who are really orphaned. They don't have somebody looking at them. That 10% will translate easily to 3,000 patients a year at least. I believe we do over 40,000 CT scans annually. So you can imagine between 3,000 to 4,000 patients anticipated prospectively will be identified as potentially needing care or attention for medical therapy and risk stratification. The retrospective we're doing, we did a small cohort number just to testing, and it was quite impressive because we could find that with a small number of CT scans we looked at over 6 weeks, we were able to identify at least 200 patients who probably will need attention, and that's we're working on working on this project to make sure that those patients are identified and contacted immediately.
Yeah. To give you some additional context behind this, out of the 3,000 to 4,000 patients that Dr. Kazia just mentioned, about 1,000 of those patients will have enough or high enough risk where it would be the same risk of heart attack as a patient who has already had a heart attack in the past. Like, these are the kinds of patients that we will be driving clinical impact for. Like, we could not be more excited about how much of a population health impact that this can have.
So really, Nish is bringing a very important point. So when I talk about 3,000 to 4,000 patients, these are patients we're going to intervene somehow by risk stratification, but there will be a significant number of them who is high risk, who require much accelerated care, such as a cardiac cath or bypass surgery or valve replacement. Again, that's why they need to be seen sooner rather than later. And we'll be able also to risk stratify those by the coronary calcium score. The numbers will help us out to identify which one needs attention faster than the others.
All right, thank you very much, Ben. Can we hear you, Ben?
I'm here. Are you there?
There we are. Yep. Go ahead, please. Ben with the View newspapers.
Yep. Thank you. So how would McLaren explain, the artificial intelligence process, to patients who might be skeptical about the technology to ease any concerns they might have? And what are some other AI applications that McLaren is already utilizing for its healthcare system?
It's a great and timely question, Ben. I think all of us in society hear about these technologies, and Nish can certainly speak to the work that his company is doing. We hear about these technologies, and we think that they help to make life a little easier for us. But I think people have skepticism too, right? In our time, I can say as a physician, as a doc, the amount of information that is available for us to see, if only we could somehow synthesize it and bring it all together. The human mind just simply couldn't work the hours that would be required in a day, let alone a lifetime, to integrate all of this information. So when I talk to patients about this technology, it is using the greater power than your individual physician or caregivers can harness to give you the most information. It's as if everything within our health record about you as an individual patient can be reviewed and understood. And so this is, I think, a giant leap forward. I mentioned earlier my role as an oncologist and the revolution that we have seen in cancer medicine with new technologies, new drug discoveries, et cetera. But our human minds can't keep all of that in place to direct technology and direct care as well as artificial intelligence can. And as we think back of, for instance, that I would equate this personally, and as somebody who's certainly been a part of science and near science my whole career, this is almost like the understanding of the discovery of DNA and the drivers of genetic causes of disease in terms of the transformative powers that it has for medicine. I can't wait to see what this impact will have for patients in the years and decades to come. But it is right for individuals to be cautious. We deploy the highest information security standards with our partners like Bunker Hill. I mentioned one that we have already in place within our stroke network that helps our doctors who take care of stroke patients around the state to recognize abnormalities faster and to intervene on those faster. McLaren's also using AI in other ways, medical documentation. Maybe some of your readers and listeners perhaps have been to a doctor's appointment where ambient AI, it's listening in the background, it's helping your doctor, your nursing staff to keep an accurate record of what happened during that medical visit. We're using that and we'll continue to expand the use of that in our practices. But this is one of many algorithms that we think are going to help make medicine more efficient, help it be use all of the information that's out there to help us gather that more quickly and make it available to our doctors so that Dr. Kazia can have that information, primary care physicians can have that information so they can have discussions with their patients about the impact. It has to have that human element. It has to have that clinical provider on the other side. It isn't a standalone. It's an augment to the resources that caregiver can deliver. I don't know if the others have comments.
Yeah, I'm going to make a comment on this because this is very important. What physicians do actually when they see a patient, they are profiling the patient. And how do I profile the patient? Family history, blood pressure, blood test, checking cholesterol, checking blood sugar. This is another tool. But I cannot keep up of profiling thousands and thousands of patients who some of them don't even have a doctor. Remember, this system is going to work for patients who have not seen a physician. For patients who have seen a physician and who have been identified, they're already in the system they're taken care of. I'm looking for those orphaned people who never thought that they had a problem. And God knows how many times, unfortunately, I see people in their 50s or 60s showing up with a heart attack, requiring major procedures emergently, but they have had all the risk factors previously, but they never really reached or they never really asked a physician, anybody to check them. Now we're going to have a flag, a red flag. We're going to be telling the patient, by the way, you really need to be seen. Here is something going on with you. It's just like seeing somebody who's walking on the street and I look at him, I said, guess what? You have diabetes. And he didn't even know he had diabetes. You need to be checked. So that's really a warning. It's an earlier way of doing it. It's going to make life much easier. for us identifying those patients ahead of time. And very cost effective, by the way.
Excellent. Thank you very much, Dr. Kazia. And we had one question come in from the chat. Justin Hicks, our friend from MLive, he asked, you mentioned pneumonia as one possible reason for a patient to have had a prior CT scan in the system. What are other common reasons for a prior CT scan? And secondly, would this AI have access to imaging scans performed outside the McLaren system?
Well, I mean, CT scans of the chest has many, many reasons, ranging from screening smokers. I mean, Dr. Clamaris can tell you that one of the screening things we do is patients who are smokers, they get a CT scan to check whether, God forbid, they have a pulmonary nodule or they are at risk of having lung cancer. There are people who might have pneumonia or flu-like symptoms, COVID-like symptoms, shortness of breath, heart failure, trauma to the chest. There's multiple chest pain, sometimes for non-cardiac, CT scan will be done. So any medical reason which require a CT scan done electively or urgently we will be able to really look into it and see whether this patient had an incidental finding. And this is the beauty of it, is you are actually, what you're doing is you have an automated detection and grading of risk of the patient of having heart disease. It's turning incidental imaging into something you can make an action on for cardiac insight. So really, any CT scan for any reason.
Unfortunately, Justin, we only can see with the images that we have, so they won't be outside of the health system, but they are at all of our McLaren associated facilities, whether that's an ambulatory imaging center, one of our freestanding emergency departments, one of our hospitals, any of our doctors' offices that have that capability. All of those will feed into this program. And Bunker Hill has gone through, along with the clearances for these, to identify the types of scans that we should be looking at. And I don't know if, Nish, if you want to talk about any further enhancements on the comments that have been made on indications or the studies we'll be reviewing.
Yeah, just wanted to highlight that um, when we do find that a patient has elevated risk, we do actually look at their holistic record, not just at the scan, to ensure whether these are patients who would benefit from follow-up or not. So if you have patients who saw Dr. Kaziha 4 days ago, probably not a good patient for us to message because they already know that they have heart disease. If a patient has late-stage cancer, end-of-life conditions, probably not so relevant to message them either. And so all of those, we are going to look at the holistic medical record of the patient to see if the patients were flagged by that Stanford AI model, looking at the CT scans, whether those patients should be notified or not as well.
Thank you. All right, we have no other hands. Any other questions? No? Okay, well, thank you so much for everybody for joining us today.